Well, hi, I'm Mark Hardy, and I'm happy to be accompanied by Jordan Grossman for Stryker's Toe-to-Toe podcast, and we're going to speak to you today on soft tissue reconstruction, and hopefully we'll have some differing opinions and different views on some commonly performed procedures, and we're going to take you from lateral ankle, maybe up to Achilles, and everything in between.
Look forward to it. It should be an interesting discussion. As Mark said, I'm Jordan Grossman. I practice in Akron, Ohio, Cleveland Clinic Akron General System.
So, welcome, Jordan.
Thank you, Mark.
This should be fun.
Yeah, it should be.
So we'll start off today talking about lateral ankle. I think this is something that is in everyone's wheelhouse, whether you're a young surgeon, an accomplished, experienced surgeon, and I think there's a lot of variation in how we evaluate these patients, determine whether they need the procedure and the implants that are used. So I'd like to take you to the evaluation phase of the laterally unstable ankle patient. You've got somebody who has a subjective symptom of, my ankle feels weak, it buckles on me, it doubles on me. How do you approach that patient? What's your evaluation process?
That's a good question. I think when interviewing the patient, I think you have to sort of get an idea of how often they're spraining their ankles, and sometimes patients don't necessarily equate a twisting of their ankle where there's minimal swelling or bruising or anything like that to an ankle sprain. So I've asked patients, how often you sprain your ankle, and they equate a sprain as, I can't walk on it, or it's sore, it's swollen, as opposed to just rolling their ankle, walking, missing a stair, or stepping on a stone and barely rolling their ankle. So I think it's important to pull from the patient how often they're even just twisting their ankle to get an idea of how often they're spraining their ankles. And getting an idea of how long that this has been going on. The other thing that you and I talk about all the time is whether or not their ankle's painful, and because ankle instability with and without pain is usually, there can be multiple diagnoses involved with that. Ankle instability that has pain, I'm usually worried about a peroneal tendon tear or an osteochondral lesion or an intra-articular impingement lesion, things like that, as opposed to somebody says, yeah, no, I'm doing fine, but if I'm out in the yard, I have a pretty good idea I'm gonna roll my ankle, or it feels incredibly unstable when I'm walking on uneven terrain. So I think it's important from the standpoint, whenever you're interviewing the patient, to get an idea of the pain, how often they do it. Again, making sure that they are rolling their ankle inward and don't have medial ankle instability, which the vast majority of patients with chronic ankle instability have lateral ankle instability. I think objectively, I try to illustrate, try to pin down exactly where it's bothering them. The vast majority of the time it's medial. The vast majority of the time it's lateral, obviously, and occasionally they'll have medial symptomatology as well. Sometimes they'll have pain within the sinus tarsi and pain over the ankle joint as well, getting an idea of whether or not you can objectively create, instability with talar tilt and anterior drawer, I think is important. To be able to evaluate, and then palpating the structures that are associated with chronic lateral ankle instability, like the peroneal tendons, the talar dome, palpating in different areas there, just to get an idea of where their symptoms are.
And I think that's a good distinction when you talk about, we teach our residents, history is the big piece of this, right? So when the patient comes in and they complain of a wobbly ankle, I think that's one faction, that's one population.
Yep.
But when they come in and say, my ankle feels weak, and it's also painful, I think that's where advanced imaging can be helpful to rule out concomitant pathologies, right? Peroneal tendon injury, osteochondral defect. So I agree with you. I think that's a big piece of the workup. And you touched upon pain in the sinus tarsi, and not to get too elemental or elementary with this, but when we look at ankle instability, I think we can classify it based on mechanical or functional ankle instability.
Yep.
And my position has always been mechanical is easy to diagnose.
Sure.
Subjectively, objectively, they have a loose ankle.
Right.
Positive drawer sign. But when they come in, they say, my ankle just doesn't feel strong. I can't trust it. But objectively, it's a normal
Anterior drawer and talar tilt are normal.
They're negative.
Yeah.
My position is that's functional ankle instability, or more appropriately termed subtalar joint instability.
I would agree. I would agree with that statement. And yeah, I don't even know if it's appropriately termed as ankle instability, because the ankle really isn't unstable. I think if you go back and you look in the literature where functional mechanical ankle instability, those terms came from, it was from all the way back in the 60s. So I think it's important that there is a component of subtalar joint instability. You and I talk about this all the time, and I think that's why the Brostrom, and with the Gould modification, reefing up the lateral arm of the inferior extensor retinaculum, works very, very well and helps and improves the outcomes, or at least literature proves that it improves the outcome, because you are reefing up, or you are stabilizing the subtalar joint whenever you are adding the Gould modification to your Brostrom.
Yeah, and I think that's where you have the subtalar joint instability patient who fails conservative care. You invariably get an MRI, right? Mm-hmm. MRI comes back and it says normal, with the exception of maybe a little bit of signal enhancement in the sinus tarsi.
Right.
And it's kind of scoffed at, right? I would tell you that that's, I think, an important finding. I think that signal enhancement in the sinus tarsi is probably attenuation of the interosseous talocalcaneal ligament subtalar joint instability.
I can't argue with that. I think that's an excellent point to sort of understand for those listening to the podcast. I think that's definitely a nugget and a pearl to people to put away. The other thing that I think is important about ankle instability is not only the static structures that are creating the stability, but also the dynamic structures, i.e. the peroneal tendons, that are also have to make sure that they're functional and that the muscle strength is appropriate. And sometimes with people that have chronically sprained their ankle, they will have deterioration of their peroneal tendons, such that the dynamic stability that they provide to the lateral ankle is lost as well. So I think it's important to evaluate the function of the peroneal musculature, as well as the integrity of those tendons, both clinically and then again, as you mentioned earlier, with advanced imaging with an MRI.
And you mentioned evaluation, whether it's gait analysis, evaluate the patient standing and sitting. How often are you correcting concomitant structural deformity with your laterally unstable ankle?
That's a good question. And for those listening, I think it's critical that when somebody comes in complaining of either peroneal tendon pathology or peroneal tendon-like pain, that you not only evaluate those patients, obviously on seated, but also have them stand, because the structure of their foot, their ankle, or their lower extremity could significantly be contributing to the reason why they're there, and that is just a symptom of the more important underlying problem, that being the structure or the alignment of their foot and their ankle. So to answer your question, I think once people that stand up and I look and they have a normal rectus foot structure, maybe even a little bit on the flatter side, clearly those people don't need any reconstruction. It's the more, and people that stand and have a wicked cavus foot, that is definitely contributing, right? The alignment is off, thereby creating the instability in the peroneal tendon pathology. And then those people, I'm aggressive with fixing the structure. Again, I make the analogy when I talk to residents about, if your tires are wearing on one side or unevenly, and you take your car and you don't simply just change the tires. You check the alignment, because probably something's wrong with the alignment that's creating that problem with your tires. So correcting the structure or the alignment of the foot, the ankle, or the leg is critical to the success and outcome of your soft tissue reconstruction. So I'm fairly aggressive with correcting those problems. Just saw a lady yesterday who has chronic peroneal tendon pathology, not as much ankle instability, but you watch her stand down and she has the peekaboo heel that's been described, and you hold her foot in a rectus position. She has a plantar flex first ray. So I am doing osseous reconstruction on those particular patients.
I think those are all great comments. What's your primary procedure of choice? When do you choose an in situ repair, reefing up the lateral capsule and the ligament, versus an allograft repair?
For a long time, the patient's weight was obviously part of that decision-making equation, and I don't necessarily use that as much. I use the chronicity, how long they've been rolling their ankle, and if the lateral ankle capsule and the lateral collateral ligaments have been shredded and repaired and shredded and healed over 8-10 years, then I've got to feel, I should assume that the quality of that tissue is not that great to do just a reconstruction, just do a Brostrom type gold. So the chronicity of their injury, the status of what the ligaments and the soft tissue structures look like on the MRI, and then intraoperatively that decision making. If it's been something that it hasn't been going on that long, I think Brostrom Golds has stood this test of time to be a very, very predictable procedure. And I think when done correctly, whether open or, I haven't started doing them arthroscopically. I don't know if you have either, but I know that some surgeons around the country have started doing Brostrom Golds arthroscopically. But I think doing that, I think that it's a very, very good procedure in the vast majority of patients.
Yeah.
Clearly, you have to reconstruct the foot if they have a cavus foot. That's also contributing to that, or your Brostrom Gold's going to fail. And I think the ones that have chronic problems, I lean more towards doing the Brostrom, but also augmenting it, or potentially bailing directly to some type of non-anatomic reconstruction, like a Grossman snook, or some type of either allograft or autograft tendon, to be able to replace the worn out lateral collateral ligaments and capsules and things like that.
So there's two good talking points. So you mentioned arthroscopic repair, and I think I had a phase where I did arthroscopic Brostroms, fell out of that, and my open approach is still a small incision.
Right.
But I still put a scope in there. I still will look for something that maybe was missed on the MRI.
How often you scope? I mean, how often do you do it on all of them?
Not all of them, and it's a good question, because then why not, right?
Sure.
But if there's something that I just have a kind of a gut feeling that maybe there's something going on in there that wasn't picked up on the MRI, I'll put a scope in quickly. And I think that's key too. If you leave it in there for a long period of time, tissues start to kind of get washed out. It's kind of like sewing toilet paper back together. So if you do scope them routinely, I think be quick with that part of the procedure. But going back to, you mentioned augmentation.
Mm-hmm.
So that that had some fan favor for a while. Maybe it's kind of fallen out of favor.
Yeah.
Do you augment your Brostrom Goulds with any other type of suture or tape from fibula to talar neck?
Usually not.
Yeah.
The vast majority of the time, I will tell you, in probably the smaller percentage of patients, I will augment it, and it's usually with like a portion of the peroneus longus, and I'll do more inherent tissue as opposed to synthetic bands and things like that. Then I will, and I'll do it rarely. I mean, more often than not, when I feel like I'm augmenting, it's really not augmenting. I'm kind of doing a non-anatomic reconstruction, like with a semitendinosis or a segment of their a split peroneus longus sort of portion of the tendon, where I'll split the peroneus longus, a long segment, and I'll take out the posterior half of it and use that as what I'm going to use for my augmentation.
And you'll run that through a drill hole and then interference screw into the fibula? Is that how you secure it?
Typically, yeah. I mean, if I'm just augmenting it, yeah, I'm just putting it in the talus, dunking it in the talus at about the ATFL insertion, running it through the fibula, getting the ankle into the position I wanted in, and putting that tendon under a little bit of tension, and then using an interference screw.
Yeah, I would agree with that. I don't think there's, for me, a place for augmentation, especially for a primary.
Yeah.
I don't know that I've, knock on wood, have really had, failure with a double row Brostrom Gould. So why augment?
Exactly. I'm along the same camp. I mean, I don't mind sort of some of the technology that comes out and some of the information that comes out. A lot of the stuff that comes out, they're mechanical studies that show that by augmenting this and putting in a rope from your fibula to the talus, lateral talus, makes it more stable. Well, duh, of course it does. But does it really translate to a clinical situation, and is it better for the patient, or is it just a product looking for a procedure?
How about CF ligament? Do you go after that?
Typically not.
Yeah, I don't either.
The times that I've cut them, I can barely get them back together if I'm trying to do a pants over vest or things like that. So I will rarely, that thick broad ligament, I rarely will go after that and augment it. Now I'll reconstruct it if I'm doing like a Grossman Snook kind of reconstruction, where I'll anchor something, I'll anchor the tendon in the talar neck, I'll run an arm down into the sinus tarsi, I'll run another arm, a longer arm, through the fibula and then down underneath the peroneal tendons and then into the CF ligament area. So I sort of, I do that reconstruction, again, with interference type screws, and again, making sure that you are positioning the hind foot as well as the ankle in a neutral alignment. And you got to be careful when you're doing sort of Grossman Snook type procedures, non-anatomic reconstructions, i.e. not Brostrom Goulds, that you don't over tighten them. I've had some non-anatomic reconstructions, which again, they're far less common nowadays with the success of the Grossman Snook, that are incredibly stiff. Some of them are stiffer than my subtalar fusions.
And I think you also have to be careful when you're doing allograft reconstruction, because I do open tunnel. I don't do blind tunnel on anything.
Same.
And I think, because I can really dial in the amount of tension that I want. So when I throw that arm through the calcaneus and it comes out medial, you have to hold that calcaneus to prevent it from going into varus when you tension on that medial side. So I think it's a good learning pearl for the young practitioners, that you have to be careful of that, because you can accentuate that hind foot ankle varus. And
I agree with you as far as the through and through tunnel, a transosseous tunnel for my tensioning and my interference. And I also think that it gives me a little bit ease that if I do over tension it, that I can take it out, you know, and take out that interference screw, realign and then retension and then put the interference screw back in.
Let's talk a little bit about positioning. How do you have the patient on the table? Supine, sloppy lateral, lateral decube?
They're almost always full lateral, almost all full lateral. It makes it difficult to, about the only exception is if I feel like if I know that I need to scope that patient. So it's uncomfortable whenever you're scoping a patient. You feel like you're working on your head with the patient in a full lateral. And I guess you can externally rotate the lower extremity even with them in a full lateral. But typically I do almost all my reconstructions with them in a full lateral position.
See, I'll put them supine. And I think for me it's just creature of comfort. You know, that's what I've always done. I think one part of that is the bump. Because you can use the bump to your advantage, you can use it to your disadvantage. And if I have the patient supine, I'll have the bump under the ankle. Because that way gravity can kind of draw or push that talus back.
Sure.
And that's where I tighten them. But you have to be careful not to put it under the heel, because the exact opposite can happen, where it thrusts the talus forward.
Yeah, because, and that's an excellent point, is that when not only are you sort of worried about the position in the frontal plane, but you're also worried that, like you said, if the heel is, even if it's not on the bump, if it's on the OR table and you've completely destabilized because you've opened up that lateral side of the ankle, it's going to shove the talus anteriorly. So making sure that the talus, the heel is suspended off of the bed, so that the talus can fall back into the ankle mortise and it's not anteriorly translated. Here's another pearl that I have found over the years, is that the degree of how much internal rotation that you get whenever they're supine depends significantly on the amount of external rotation when they lay on the OR table. So I've learned that you can probably, if their feet are basically arms of a clock, you know, and this is at about 3 o'clock, you can usually internally rotate about 3 hours. So if they're laying with their toes pointed towards the ceiling and you put a bump in, you can get the foot entirely almost into like they're in a lateral decubitus position. But if they're laying down and you watch them laying on the operating room table from the foot of the table, and their legs, their fifth mets and their lateral foot is on the OR table because they lay so externally rotated. When you put a bump underneath there, you're lucky to get their toes up to about the ceiling, up to about 10, 11 or 12 o'clock. So, and in that situation, it's so much, I think it's much more uncomfortable and challenging, because now you got to have a resident or a student holding that leg internally rotated as you're trying to work on the lateral, on the peroneal tendons or the lateral ankle. So sometimes you can get an idea of that whenever you go to visit them in the pre-op area about how much natural external rotation that they actually have, and whether you need to go full lateral or you think that you can put a bump, put them supine with a big old bump.
Talk about your fixation construct. So I think we both agree we do double row technique. So what are your implants of choice, and how many do you put below? How many do you put above?
So I used to. When I would, before the double row technique became in vogue, or the more appropriate way, I would just use a single row, and I use an all suture anchor. I use the Stryker Sports Med line. It's called I believe it's called the Iconics, and it's an all suture anchor, and drill hole, tap it in, and I usually use one sort of, I decorticate the anterior fibula. Clean all that up so that what I'm reefing up heals to the anterior lateral fibula, and I put two of them in, and they each have two they have two sutures or 4 needles per. So I'll put one sort of higher up on the lateral malleolus and then one down by the ATFL insertion, and I'll tap them in, and then I'm grabbing the lateral capsule as much as I can, and including incorporating the lateral arm of the inferior extensor retinaculum, making sure that I stay out of watching the peroneus tertius, watching the superficial perineal nerve in that area. And that's the other thing. My incision is not the half moon, the curvilinear incision over the anterior aspect of the fibula. I use more of an intraneural incision over the lateral aspect. It's sort of, I curve it up the fibula, and then I come down along the inferior fibula over the sinus tarsi. I stay intraneural, number one, and it gives me a little bit better exposure to the retinaculum, that I can grab more of that tissue.
I do something similar, but mine's more linear, because if I get in there and I'm fooled, and my capsule and my ligament
Were you ever fooled?
Fool me once, fool you twice. What? How's that go?
How's it go?
So I'll make a linear incision, because if I find that capsule and ligament is really attenuated and wispy, and it's not going to be robust enough, to your point earlier, I can go up and I can grab part of the peroneus longus, and I can do an augmentation through a drill hole and an interference screw.
For sure.
So I do double row. I tend to use the Citrafix anchors. I'll do 2.9 distally after I've kind of.
And how many sutures are you able to anchor into the fibula with those?
So if it's a wider fibula, I'll do 3 on the bottom, and then I'll do 2 up top. If it's a narrow fibula, then I'll do 2 on the bottom, 2 up top, and I'll take one piece of suture and put up into each of the superior holes.
Okay.
But it can be a lot of anchors, but I find that the majority of my patients, it's 3 on the bottom, 2 on top.
And what sort of caused you to migrate to using the Citrafix as opposed to, you were using all suture anchor beforehand?
So I was using that. I was using sonic anchors as well. I like the knotless technique that Citrafix can afford you. I like the fact that the implant degrades down and is replaced by bone at some point. Because if I do have the tendency, if I overcook them, if I over-tighten them, in theory, at some point that anchor is going to dissolve, the eyelet's going to snap, and my suture will give way. By that time, it's already been replaced by native tissue.
Native bone.
And I don't have to go in and cut out suture. I don't have to go in and remove anchors because I've made them too tight.
Yeah.
And the technology just makes sense to me. I think as good as PLDLA anchors are, like the sonic anchors, they still have a little bit of a, kind of a cocoon that surrounds them, and they might not be completely replaced by bone.
Gotcha.
So that technology makes sense to me.
Gotcha. You've always been ahead of the curve.
I am.
So I still use the all sutures. I've gone to a double row technique, number one, because of certainly what research has shown, I guess in mechanical studies, that double row works better than the single row. The other reason why I went to double row is so that I can fold my knots down, and it really helps to sort of suck down the tissue that's against the anterior lateral fibula, sort of that cuff. It reinforces that. And then I use this Omega anchor from Stryker Sports Med side, and I go up the fibula a little bit higher, and then I'll get all 8 strands through the omega, and I'll anchor that. And I run my drill for the second row, sort of from posterior lateral to anterior medial into sort of the distal or the proximal metaphyseal area, proximal side of that distal metaphysis, so that I can have enough bone to anchor it in there. So there's 4 needles per iconic. So I have 4 sutures that grab capsule and extensor retinaculum, and then I throw them, cut off the needles, and then position the foot and the ankle, and then tie them all down, and then do my double row.
Do you raise up a periosteal flap to cover the entire repair?
No,
No,
no, because the double row sort of pulls down whatever excess of the capsule, pulls it down to that anterolateral, and there's really, I don't think that there's any need. And I've been incredibly happy with that. I mean, I read some literature, and I read the literature, and they talk about these things failing and, you know, need for augmentation. And I mean, one of my most predictable procedures is a lateral ankle stabilization with this technique that we're talking about.
yeah.
I mean, with the anchors that are available, you know, through Stryker, the Citrafix, or the Sports Medline anchors. I mean,
It's a low failure rate.
it is a very low failure
Yeah.
rate. So, I mean, every now and again, you'll have one that fails, and maybe it's because I missed something about their structural deformity. Maybe they sprained their ankle early on. You know, maybe the resident did something that they shouldn't have done, and they caused it to fail. There's always the residents to blame,
It
right?
is, right.
So, but by and large, it's an incredibly predictable procedure.
Good.
How about your postoperative course?
Yeah.
What's your time? What's your time that you start mobilizing them? When do you start walking them? When do you start rehab?
Yeah, so that's a great question. So I'm still a little bit conservative on time to weight bearing, full propulsion. So at 2 weeks, I started doing range of motion, because I think any type of soft tissue reconstruction, you can't immobilize them for long, otherwise you kind of negate what you're trying to achieve.
Right.
I have them weight bearing probably around 4 weeks in a boot. They're still apropulsive. At 6 weeks, then I start doing, I'll convert them to an ankle brace, an ASO brace.
And how many weeks?
About 6 weeks.
About 6 weeks.
I'm very slow, I'm very reticent to get those type of patients, and we're going to talk about Achilles ruptures in a little while, but my lateral ankle instability patients and my Achilles rupture repairs, I'm very slow to get them into formal PT.
Why is that?
Because I want them to be stiff. I'm not trying to get them to be stretched out. It's not like an ankle fracture that's stiff after my repair.
Right.
I want them to be a little bit on the stiff side. I can always correct that downstream, you know, 3-4 months if I need to.
Works its way out.
It does,
Yeah.
because PT is not going to make them tight.
Right.
Now, where I might get them into PT a little bit earlier than that would be with gait training, maybe some strength training, but nothing stretching. They're not on a BAPS board. They're not on an incline board. I want that thing to be tight for quite a while.
Okay. Yeah.
Yourself?
I'm similar. You know, maybe a few weeks. I mean, I think weight bearing in a rigid rocker bottom boot has minimal strain or stress on my lateral ankle reconstruction. So a lot of times I'll get them walking, if they want to walk, by about 2 weeks. I mean, the reality is that after the reconstruction, and if we're just talking just solo lateral ankle stabilization, certainly if I do a calcaneal osteotomy or first med osteotomy or something, other procedures that would prevent me from getting
Bony work.
What's that?
Bony
Yeah,
work.
yeah, some osseous reconstruction. Then I won't get them walking until obviously about 6 weeks because of the other procedures. But if we're purely just talking about just the lateral ankle stabilization, then yeah, it's about 2 weeks I get them mobile. 2 weeks I get them trying to put some weight on it. Weight bearing is tolerated in a boot, and then I'm like you. I'm a little bit reticent as far as getting them into the hands of a therapist. Sometimes I think the therapists think that they got to start working out the stiffness and everything like that, and they start cranking on this, and I worry that may compromise the healing process in my repair. So I'm like you. I'll hold off on therapy for, what'd you say, about 2 months, 2-3 months, until I get them in the hands of the therapist. And you know, and quite frankly, I mean, some of the patients don't even go to therapy, and they say I can do those things at home. And while I don't necessarily agree with that, because the knowledge of a physical therapist and the tools and instruments that they have there are much different than what a lot of patients have at home. It's, because what they have at home is probably just a TheraBand and the sheet of exercises that they get in the office. So I think therapy is valuable for these patients. Some patients only need a few visits and some need more. I think the ones that decondition more probably need a little bit more therapy, but I think at least getting them to the therapist for a couple of visits, I think, is beneficial for them.
So post-op protection, splint, cast, boot?
Yeah, so boot, I'll keep them, I'll get them weight bearing in a boot or partial weight bearing or weight bearing is tolerated in the boot at about 2 weeks. And I'll generally keep them in there for, like you, about 6 to 8 weeks. And then I'll transition them to a lace-up type ankle brace. And I'll keep them in that lace-up ankle brace for a minimum until they're about 12 weeks post-op and encourage them to get out of that brace and let the ligaments do what they are supposed to be doing and not being lazy because they have external stability and support with the brace.